The funny bone in the upper arm. What exactly happens when we catch our elbow on a hard surface and we experience the sensation that we do down the medial aspect of the forearm? So, to understand this better, we need to appreciate the anatomy. So, very briefly, looking at the forearm, we've got two bones in the forearm, and this is your ulna, and this is your radius. Now, in the anatomical position, it's held like so. So therefore the ulna is on the medial aspect of the forearm and the radius on the lateral aspect of the forearm. Then we have the arm itself, i.e. the humerus at the top over here. Now the ulnar nerve actually runs through what we call the cubital tunnel, and the cubital tunnel essentially is formed by the humerus bone, i.e. the bone in the upper arm, and the ulna itself. And there is actually a ligament that runs over the actual ulnar nerve, thus forming the cubital tunnel itself, and that's called or referred to as the cubital retinaculum, also known as Osborne's ligament. Now Osborne's ligament runs from the ulna down across to the medial epicondyle of the humerus. So long and short is we create a little tunnel over here through which the ulnar nerve will pass. Now on the back of the upper arm we have the triceps muscle. So the ulnar nerve actually passes medial to the medial aspect of the triceps muscle. So it's on the inside of the triceps muscle, which inserts onto the olecranon process, part of the radius. Okay, so that's why when we actually cross that joint, the triceps muscle from here crosses the joint, and therefore we can extend the elbow. Once it's passed through that little tunnel, the cubital tunnel, it then enters the fascia, and it will be running through and past the muscle fibers of the flexor carpi ulnaris. So now let's get back to the usual bit of, so when we move around and we catch our elbow, we catch this bit and we have that sensation running down. So the situation is you've caused a very transient, a temporary physical insult and or compression to the ulnar nerve, and that is what sends the signals down. Now in the absence of that, in the absence of trauma, there are patients who will also experience the same thing. Typical examples include when patients say they're asleep in bed and they start to feel the numbness passing down, and usually it's the two fingers, the little finger and the ring finger, but definitively always the little finger. More often than not it's the ring finger as well. Further exploration or questioning reveals that the patient has actually been lay in a position where they have got a prolonged period of elbow flexion. And so if you appreciate that, what we're doing is, again, we go back to the anatomy and we are compromising the actual aperture itself, the size of that tunnel through which the ulnar nerve passes. And so because compression of the ulnar nerve, hence the symptomology that is, and that again, as patients will say, is relieved once they actually straighten out the arm. Other situations for the same is when patients will be on a handset for a period of time, again elbow flexion prolonged. People who work in professions where they've got a lot of forearm muscle use, so manual therapists, massage therapists, osteopaths, chiropractors, these kind of folk will also have, as well as plumbers and other tradesmen. So these kind of things can happen. People who go to the gym, avid gym goers, again, when they are doing a lot of forearm strength building, they can have the same issue. Now, in those circumstances where there's an occupational hazard, generally what happens is these symptoms will become irreversible, or otherwise they become less responsive to conservative measures once the cubital tunnel, the aperture becomes compromised by around about 80%. Now it depends on the reference you read, but once you've got about an 80% compromise of that tunnel, then those symptoms become more constant, more permanent, and unfortunately usually they are not quite as responsive to conservative measures the likes of manual therapy and splints, etc., if you so wish, and therefore they have to undergo surgical correction to essentially open up the tunnel. Now again, there is a bit of a kind of a double-edged sword here, because the surgery itself will potentially lead to some scarring, and so is surgery as successful? I mean, there are cases which are not successful, and the most most plausible reason for that is because the scar tissue that then develops again reoccupies that cubital tunnel, for which the purpose primarily was to actually increase the size of that aperture. So there you have it, the funny bone in the upper extremity, i.e. in the arm, the ulnar nerve, and the situation with that. Thank you for watching.